Good morning, everybody. Thank you guys for being here for another exciting case competition. This is the semifinals for the peripheral challenging cases. My name is Dr. Fote. This is Dr. Lee. We're going to be co-moderating this event. We have a nice, esteemed panel of local colleagues here to go over the cases, do some discussion. Please turn off your phones, and we'll get started with the first case here. Dr. Lee, would you like to present the first one?
Great. We'll invite Dr. Ahmed Elborae to present to us an exciting case on journey to the center of the heart, not the leg.
Good morning, everyone. So, journey to the center of the heart. The journey of any peripheral, coronary, or even structural intervention starts with gaining access. So, our journey started with a 59-year-old gentleman known to be diabetic and hypertensive with previous history of long-standing bilateral lower limb edema, presenting to ER with repeated attacks of syncope. His ECG revealed Mobitz type 2 EV block with 3-to-1 conduction and a very slow heart rate, 30 beats per minute. His echocardiography was normal apart from dilated inferior vena cava. So we have decided to insert a temporary pacemaker wire for this patient. After gaining internal jugular venous access, every time we directed the pacing wire towards the right ventricle, it take an abnormal course downwards towards the abdomen. And we repeated this maneuver every time, and it went to the abdomen. So for the sake of time, I have changed it into a femoral axis and successfully insert the pacing wire through the femoral venous axis. But to figure out what is going on, I have decided to inject a 10 cc of diluted contrast through the internal jugular venous axis, and here what we get, a dilated venous structure that drain downwards into the abdomen with nothing entering the cardiac shadow. So what is this? Let's go back to our normal anatomy. Apparently, this structure is a dilated azygos vein draining the innominate vein. But why nothing entering the cardiac shadow? We did CT chest with contrast, and here is the 3D reconstruction imaging, showing that both innominate vein drain into a dilated azygos vein that went down to the abdomen and drain into a dilated inferior vena cava. And apparently this patient has bilateral absent superior vena cava, and the whole venous drainage of the body went back to the heart through the inferior vena cava. Now we understand why this patient has long-standing lower limb edema and why he has a dilated IVC in his echocardiogram. And we understood why the pacemaker wire every time went to the abdomen and nothing entered the heart. So back to the main problem. This patient needs a permanent pacemaker. How to insert a permanent pacemaker in this difficult anatomy? We left with two options, either a leadless macro pacemaker, not available in my center at that time, or epicardial pacing through a limited lower thoracotomy incision, and that's what we did. So a quick review of literature. Absent superior vena cava is a very rare congenital heart disease, representing less than 0.1%, and almost always accompanied by persistent left superior vena cava. 1/3 of these patients present with rhythm abnormality, and this anomaly accidentally discovered while attempting inserting pacemaker wire, like in our case, or even in more complex cases, accidentally discovered while attempting venous cannulation during cardiac pulmonary bypass. But absent both superior vena cava is extremely rare, with only 2 reported adult cases, and this one is a 30 case. So, although this is not a pure or a true interventional peripheral case, but we have some lessons from this case. First one, know your anatomy. Because if you don't know the normal anatomy, you will not identify abnormal anatomy like in our case. Second lesson, be ready for a challenging anatomy and roam the unknown as we did. third one, out-of-box solutions for unusual scenario, and here intervention innovations come. And finally, thank you.
Excellent case. Certainly that can be very challenging, especially in the middle of the night. You know, you had just woken up to get called for this temporary pacing wire. I think you did an excellent job. Indeed, a very rare consequence. And sometimes we get called to do these cases, especially in patients that have had, for example, a heart transplant, and you're trying to do a temp wire or a swan through the IJ, and you can't get access. I think it's important to be able to think on your feet, as you did, and look for alternative access points.
Thank you.
Any comments from the panel?
What happened to the patient? Did you end up putting a leadless pacemaker?
Yes, he's doing fine after inserting the epicardial pacemaker. No syncope anymore, but still complaining of the lower limb edema. Slightly improved was diuretic, but still presents.
Okay.
It looks like that venogram that you did was very helpful to reconcile the abnormal anatomy, and I think it's a great lesson that when things aren't making sense, you know, we do run into anatomic abnormalities with some regularity, not as dramatic as this, but it's always better to get more information before you start pushing harder, because that's when you have complications. So it's great to get the venogram. That was very helpful.
Thank you.
Thank you.
Thank you very much.
So up next, we have Dr. Kristopher Aten. He's here to present on femoropopliteal pseudoaneurysm, a rare complication of self-expanding Nitinol stent fracture.
Thank you. So this case may not be unfamiliar to you if you're at Dr. Russell's case-based presentation yesterday. This is a case of a popliteal or a femoral artery pseudoaneurysm. It's the green. Okay. So this is a relatively young patient, a 36-year-old female who had a pretty extensive cardiovascular history, especially for her age, who came to clinic complaining of worsening right lower extremity claudication pain. And at the same time, she was also complaining of reoccurrence of pain in her left lower extremity about a year and a half after she had a previous left SFA intervention. And so her previous history, she did have ischemic cardiomyopathy with several PCIs in the past. She had the aforementioned left SFA intervention about 18 months prior, and there was some question about whether or not this patient may have some sort of vasculitis. She reports a strong family history of moya and has obviously had quite a vascular history herself given her age, but at this point her serologic workup for the typical suspects was negative, so sort of to be determined. So 18 months previously, she had presented with limb ischemia and a left heel wound. And so at that point, she was taken to the angiography suite for a left SFA angiography and intervention. Her ABIs prior to that were non-compressible, so it was based on arterial duplex showing flow-limiting lesion. So this is her index intervention on the left here. You can see that she's got a proximal CTO of the left SFA after ballooning multiple areas of flow-limiting dissection, and so she did receive 2 overlapping stents that were 6-0 at that point. And so after she followed up from that initial intervention, her heel wound resolved, her pain was significantly improved. Unfortunately, she did have a bleeding diathesis, and so her antithrombotic and DAPT was complicated to the point where she actually required hysterectomy for symptomatic fibroid-related bleeding. But overall, she did do well. And so now she comes back, she's got this worsening pain on the left side, and she's also got lifestyle-limiting Rutherford class 4 claudication on the right. And so, just given that she was maxed out on medical therapy, obviously angiography was performed on the right. And here we see a similar CTO that was intervened on very similarly with ballooning and then followed by stenting given the flow-limiting dissection. And then we looked at the left because obviously she was having new pain that didn't quite make sense given that her ABI seemed to be improved, or her duplexes, excuse me. And we see on the fluoroscopy that there's a pretty significant type 4 stent fracture and then potentially some other sites of fracture as well. And then angiography showed this large serpiginous appearing pseudoaneurysm here. And then here on the DSA, you can see that that aneurysm is relatively large. And so here's a CT of the stent, and you get a better appreciation of where the stent fracture is and how comminuted it is in certain points. And you can very clearly see the relationship between the fracture and the pseudoaneurysm. So the clinical challenge is, have we found the pseudoaneurysm just as a bystander? Is there some other process that's driving her new left lower extremity pain after intervention? She still had good 3-vessel runoff after the intervention, kind of unclear if the pseudoaneurysm was flow limiting. And if it is involved, which it would seem reasonable that it is involved with her pain, what's the best treatment strategy for this? And so looking at the literature, one of the things that I really wanted to bring up is that right now, stent fracture in general is a very common occurrence, but there's still, the jury's still out on whether or not it is truly impactful on primary patency rates. So 3 of the bigger studies that are still relatively small that have systematically looked at the rates of stent fracture show that it's anywhere from 10 to 25. Some have even reported upwards of 30% when you systematically look at limbs that have received stents in the FPA. And so obviously this is a common issue, but we've still been unable to really settle the debate about whether it does have a long-term effect on primary patency. And so that's an area that does need more research. But we do know that this is a rare but reported complication of more severe stent fractures. And so there are several cases in the literature, and there's been variable approach in how to treat those pseudoaneurysms when they do occur. So one case, obviously, of a ruptured aneurysm received an open repair. In general, the rest have received covered stent repairs just because of the challenges that can obviously be posed with surgical intervention in these cases. And so here we see the angiograms from the fix of the pseudoaneurysm. So initially just trying to go in with a straight wire, difficulty traversing the area of fractured stent here. And so he went in with a Rosen wire here that passed the area through the comminuted stent fracture too. You can also see that just in the 6 months since the original CT, just how much more discontinuity in that area of stent fracture is. And so obviously this is something that warranted repair in this case rather than monitoring. And here is just an angiogram. You can see that the pseudoaneurysmal segment has enlarged since the previous angiogram. And then here is the Viabon covered stent graft being deployed. And then here's a final angiogram after the Viabon stent was deployed. And you see that there's good exclusion of the pseudoaneurysm, significantly improved flow. And so, you know, I'm a third-year internal medicine resident, so I don't have the technical experience or learning. So for me, some of the key takeaways as someone who is not necessarily intervening on patients yet, but seeing them in clinic, dealing with people concerned with their claudication and having symptoms is the importance of knowing that stent fracture is not uncommon. And while these severe, sequelae of them are, understanding that this is a possibility, and so that when someone who has had a previous intervention comes in, something doesn't quite make sense, maybe they have new pain all of a sudden, knowing that this is something that needs to be evaluated because it could be involved. And obviously the other take-home points are that this is a reported but relatively rare complication, and so right now we don't have a well-validated treatment algorithm, and so most of this is based on expertise in your local center. and your own experience with your vascular multidisciplinary team. And so making sure that you pause and take a minute to come together as a heart team or a leg team to really determine the best treatment strategy is going to give the patient the best chance at having a successful re-intervention for this. All right. Thank you.
Nice case. What a difficult patient for sure at the age of 36, having undergone all these interventions already. We might have missed it, but did you mention what kind of stent was placed originally?
So she had, I believe there were Everflex stents placed originally in the left SFA.
Okay. And any consideration at any point in time to maybe proceed with a bypass or an open repair given her young age and the propensity for these stents to fail?
Yeah, so there was a pretty extensive discussion with the vascular surgeons there as well. I think it took them about 6 months to really come together and decide that a peripheral intervention was just better based on her case. I think there was some concern about bypassing her, having her previous bleeding diathesis and just the complications of having to proceed with an open surgery in her case. But.
What was your antiplatelet and antithrombin choice afterwards?
So after the
covered stent.
Viabon, that I'm actually not sure about.
Yeah, because I would argue if she has bleeding problems, I treat Viabons like, synthetic bypass grafts. You worry about thrombosis of those as well. So I'm not necessarily convinced that you made her safer by putting a covered stent there.
The best interventional cardiologists I know and the best cardiologists I know are great internal medicine doctors. So I'm not going to ask you any technical questions about the case, but what is her diagnosis at the tender age of 36?
For
Why does she have
her
peripheral artery disease that's
milieu.
occluded both of her SFAs? That angiogram is not normal. There's significant pruning and the arteries are very small. It is strongly suspicious either she has raging, poorly controlled type 1 diabetes mellitus, or there's some medium vessel vasculitis going on.
Right.
And so what is her diagnosis?
She could certainly have like some sort of Takayasu or some.
Is she
similarly,
something
but-
I wondered? Yeah. So she usually that affects the proximal vessels. Is she of Asian descent?
She's not, which is why this reported family history of the Moya Moya was interesting to us as
Yeah,
well. She's Hispanic in origin.
Okay, it's very dramatic. The pseudoaneurysms that have developed, so makes me wonder that there's some underlying pathology going on that when you look a year later, the same thing is going to be present on the right leg. And so I don't think we have the diagnosis yet. And so the point is when things don't make sense, just like our last case, that anatomy didn't make sense, you really need to pause and stop and say, hey, do I have the diagnosis right, or am I what I'm looking at what I thought I was looking at? So just don't lose sight of that.
I think that's great points. The other teaching point is, I know we think about Asian descent for Takayasu's. I have a big clinic of Takayasu's patients. None of them are Asian. So just always think about females with premature disease.
Just another question that I have for you. So it's pretty interesting how much disease she has. I'm not trying to put you in the spot here or anything like that. You said rest pain. Do you have any angiograms of what was going on below the knee? It's rare for people with just SFA occlusions alone with a good common femoral, good profunda, and good vessels below the knee to have rest pain. There's got to be something going on below the knee most of the time, more than 90% of the time. Do you have an angiogram of what was going on below?
I don't have them in the presentation.
And I'll tell you why I think this is important. I personally, I have a pretty busy peripheral practice, and I don't revascularize claudicants unless they beg me to. Sure as heck, a 36-year-old, I probably would be really reluctant to do anything because I don't know how long they'll stay open. And like you've shown, revascularization, endo or surgical, is not without problems downstream, right? Often an occluded vessel is actually the safest thing in these young people, right? So, when, it's easy to say people have rest pain. Rutherford 4 is the most nebulous staging in the Rutherford system, right? You can just say anything's rest pain, really. So, Yeah, neuropathy can be rest pain. There you go. So the teaching point for you, since you're internal medicine, is you have to make claudicants beg you to treat them with any sort of revascularization. And if you say Rutherford 4 and then want to treat them, you better have a damn good reason, because this is exactly what happens further downstream.
Thank you.
Other comments? Thank you.
Thanks.
We're going to move forward. Next presentation is going to be sneaky subclavian cause of post-CABG Steele syndrome, Dr. Alexander Warner.
All right, good morning, everybody. My name is Alexander Warner. I'm an internal medicine resident at the Medical College of Georgia. It's an honor to present on behalf of some of my colleagues, Dr. Mehta, Dr. Sehu, Dr. Shukla, and Dr. Sharkawi. We did change the title. I like sneaky subclavian, but we switched it to myocardial ischemia due to subclavian artery Steele syndrome. So I don't have any disclosures. So we have a 58-year-old man who presented as a transfer from outside hospital. He had obesity, hypertension, hyperlipidemia, OSA. He was on CPAP and was a current smoker. He was transferred to our facility on an intra-aortic balloon pump. His EF at that time was 37%, and he was transferred for evaluation for an urgent CABG. Came to us on a nitroglycerin drip, and then the concern was for his critical left main and ostial LAD stenosis. So this is the initial angiogram that we got from the outside hospital. You can see that distal LAD disease as well as left main disease. That was the reason for referral. So he was taken initially for an urgent CABG. They did a Lima to LAD bypass, SVG to OM1 bypass. So why is this a peripheral case? Post-op day 1, he was working with physical therapy, developed some dizziness, shortness of breath, and orthostatic hypotension. Additionally, his cardiac index, he was in shock at that point. He was on norepinephrine, epinephrine, as well as vasopressin. We saw some EKG changes. There were inverted T waves that went to Q waves in V1 and V2, so he was taken emergently to the cardiac cath lab. So here initially is the coronary anatomy. I promise I will get to the peripheral part in a minute. The left main and ostial LAD, nothing had changed there from his native vasculature. His SVG was occluded. So the surprise or the challenge when we took him and did this was actually his subclavian artery was completely occluded. So at that point, we kind of had a decision on our hands that we had to make, and that was our clinical challenge. We have a gentleman who presented with end-stem. He had recently undergone a CABG. His OM graph was down. He was in cardiogenic shock. And then the decision is, what do we do with this occluded subclavian artery? And so kind of our resolution to this challenge was, given his ischemia, the cardiogenic shock, we went with the decision to revascularize his native left main and LAD. And we decided, since the left subclavian artery was completely occluded at that time, that we were going to defer that intervention till later. So our approach to the coronary anatomy was we did angioplasty to the LAD, left circumflex, put a drug-eluting stent 3x5 and 30 into the proximal LAD, did kissing balloons, that's what's present here, did some optimization afterwards, and he was still on an intra-aortic balloon pump after this case. So our resolution to the challenge was, kind of in hindsight, he did have some symptoms of dizziness when he was working. We were concerned about the subclavian artery stenosis, but we stabilized him and he returned as an outpatient. So initially we tried to get antegrade access through, we had right femoral and left femoral, 8 French and 6 French sheath, respectively. We were unable to cross anterior grade, so we went retrograde and finally were able to cross with a glide wire advantage. So we did overlapping stents. First we did a Vibon stent that was 11 by 39. Weren't able to upsize to the 59 because we were concerned about the vertebral artery. And then an express stent was placed after that because we had a little bit of ostial subclavian artery that was still exposed. So we wanted to make sure that was still treated, and post-dilated both of those stents. So here's our initial angiogram. We can see, let's see if this works. Our vertebral artery is up here. We're looking for our Lima graft here. Not great flow through it. So this is our final result. We can see that we have the 2 overlapping stents here. Here's our vertebral artery, and our Lima graft is coming down here. So key learning points for the operator and the team at this point is remembering subclavian stenosis, in this case Steele, as a cause of ACS after CABG. So the incidence is about 0.6 to 6.2%. That goes up precipitously to about 11% if you have both coronary artery disease as well as peripheral artery disease in folks undergoing CABG. The next thing to remember is screening for subclavian stenosis prior. Unfortunately, we weren't able to. He was on nitroglycerin, had refractory chest pain at that time, so he was taken urgently. But considering bilateral blood pressure measurements, some what I've seen is between 10 and 20, or greater than 15 difference. Also, you can use ultrasound to evaluate as well. And how we approached our case is we kind of dealt with the cardiogenic shock first, revascularized his native vessels, and then we did defer his subclavian intervention to outpatient. So there's a couple of different things in literature that have popped up as far as taking down the lemma to LAD, doing a bypass, or as far as doing stenting. So the ESCS guidelines from like 2011 recommended trying to do stenting first, and then surgery is kind of a bailout option, or a failing stent option, if you will. Oops, sorry. Here are my references, and thank you for the opportunity to present at the conference, and any questions, would love to take them.
Great case. So few things. I'm going to put you on the spot a little bit. So what do you think the incidence of subclavian artery stenosis, significant stenosis, is in patients undergoing CABG?
Yeah, so between 0.6 and 6% is what I saw, and then if they had peripheral artery disease, it went up to 11 is what I found in a review article.
So we published that in about 2009, Berlakis and myself. It's about 3% all comers, so it's not trivial, right? I mean, so I think the cheapest test is really checking that blood pressure in both arms, and it's simple. You don't need ultrasound or whatnot. Ultrasound can be challenging for subclavian artery disease, and you really want to look for retrograde vertebral flow. Was the patient right-handed or left-handed?
This is a great question. I believe he was right-handed, but I'm not sure.
Yeah, so it's almost never the case that they get steal symptoms, dizziness, from their left arm if they're right-handed. It's, we just don't use our left arms in day-to-day activity enough, so it's a little unusual. Most of the people who actually get symptoms of that left subclavian, stenosis, oftentimes it might be arm claudication, hand claudication, tingling, pain in that extremity. But actual symptomatic steal is rare in a right-handed person.
That's a fantastic case. I agree. The simplest test to do is actually a bilateral upper extremity blood pressures. We oftentimes, at least in our institution, obtain ABI as well before CABG, in addition to the venous mapping. As a vascular reader, sometimes you actually pick up these subclavian stenosis patients before their bypass through that route. Given that it was an urgent case, understandably, I think a bedside bilateral blood pressures would have been helpful. Secondly, sometimes the surgeons actually do intraoperative testing of the lemma to ensure that they have adequate flow for maturation of the LAD. So that's something that's not to be missed. In this specific patient where it's a pretty dramatic occlusion of the subclavian artery, they may actually be able to detect a decrease in flow, perhaps suggesting that that bypass isn't necessarily going to mature.
Anybody else? Just a short technical question, not to put you on spot, but maybe Dr. Lee can help us. That stent that you guys put in 1159 VBX seems to be awfully big for a subclavian. I've never put in 11 millimeter VBX in a subclavian. Usually it's mostly roughly 8 to 9 for men and 7 to 8 for women. Did they do an IVUS and then choose 11? What do you think, Dr. Junley? You do a lot of IVUS on OCT, I know.
I was actually surprised by the size 11. Typically, I agree with you, typically the subclavian tends to be about 8 to 9 in most people. So that may be a little bit oversized. I would urge all the fellows here in the room that especially if you intervene upon a subclavian, I almost always IVUS those cases to exactly land your stent where your ostium of the subclavian is, as well as avoiding jailing the vertebral artery.
You certainly don't want to be undersized, but your goal is to get rid of that gradient, essentially.
Yeah, I think they did. So I think they did it under angiography in the cath lab, and they did it 11 by 39. They were watching where their vertebral artery was, like you had mentioned. And then as far as doing the ultrasound, typically if they're scheduled or if they're on the cardiology team, we will screen for that. Unfortunately, we didn't have that preoperatively. We weren't involved in the case at that point. It was a sticky patient, and ultimately we got involved after.
Thank you.
Great. We'll invite up the next speaker, Dr. Thuy Pham, to discuss stick, snare, shockwave, and stent, how we tackled severe bilateral iliac disease.
Good morning, everyone. I'm Thuy Pham, an endovascular fellow at the Baylor Scott White Heart Hospital in Plano, where I just finished my interventional year there as well. This morning, I'll share with you a case of stick, snare, shockwave, and stent, how we tackled severe bilateral iliac artery disease. I have no disclosures. Our patient is an 83-year-old female referred for carotid artery disease, abdominal aortic aneurysm, and bilateral iliac artery disease. She had possible amaurosis fugax and bilateral hip claudication for about 6 months. She had chronic shortness of breath with no chest pain, TIA, CVA, or non-healing wounds or ulcers. She had a carotid endarterectomy in 2018, but on most recent carotid ultrasound, she was found to have moderate to severe left internal carotid artery stenosis. She had a AAA diagnosed back in 2017 at 4 centimeters that was stable over the years, but most recently it enlarged to 4.8 by 5.1. She had moderate bilateral iliac artery disease in 2019, but on most recent imaging, she had severe right common iliac artery disease and occluded left common iliac artery. She rounded that out by being a 60-pack year former smoker, prior lung cancer, COPD on chronic home oxygen, and hypertension and hyperlipidemia. So we took her to the lab for a carotid angiogram, which she was only found to have mild bilateral carotid disease. But using our right common femoral artery axis, we were able to do a selected angiogram here to evaluate her PAD. And we found her significantly calcified AAA, an 80% stenosis of her right common iliac artery with a 23 millimeter gradient, and occluded left common iliac artery. So she needs an EVAR, but she also has severe bilateral iliac artery disease. So what's your next step? We decided to repeat the CT abdomen pelvis at 6 months, which confirmed a 4.9 by 5.1 abdominal aneurysm with severely calcified bilateral iliac artery disease. So we consulted our vascular surgery team, and she was deemed to have not an infrarenal neck for a traditional EVAR, which meant she would likely need a 3-vessel physician-modified endovascular graft repair. To avoid any challenge or complications of a large bore device delivery in a complicated PMEG case, we decided to start with percutaneous intervention of her bilateral iliac arteries, followed with staging of the PMEG at a later date. So we started with 6 French sheets in the bilateral common femoral artery. We advanced a 5 French omniflush from the right common femoral artery to obtain a distal aortogram, which confirmed the severely diseased right common iliac artery and occluded left common iliac artery. We had unsuccessful attempts to cross retrograde from the left common femoral artery of the left common iliac artery using a Navicross, Command 018, and Astato 30. So what do you do next? We went up. We attained right radial artery access to attempt antegrade crossing of the left common iliac artery. We started with a 6 French short sheath, a 5 French vertebral catheter, a glide wire, Navicross, Command 018, and Astato 30. Still unsuccessful. So we switched out for a 6 French 105 centimeter destination sheath using the 5 French vertebral catheter and an Astato 30, and as you can see here, we're finally able to poke through that left common iliac artery occlusion. We then used a 10 millimeter gooseneck snare to externalize that antegrade wire out the left common femoral artery. And then we performed balloon angioplasty at the left common iliac artery with a 3x40 crustella and a 5x20 Sterling. We then switched out our 6 French sheets for 8x45 sheets to perform L6 shockwave, first of the right common iliac artery and then the left common iliac artery. And we deployed 10x57 Visupro stents, the left side first, then the right, and performed a final kissing balloon angioplasty. And here's our final results. So the resolution of our challenge of a severe calcified AAA, but needing a PMEG in the setting of severe bilateral iliac artery disease was to stage the bilateral iliac artery percutaneous intervention first, followed by eventual 3-vessel PMEG. She was actually supposed to have that PMEG this week and was hoping to scrub into it, but she rescheduled to September of this year. And then the learning points is the multifaceted approach of the percutaneous intervention of our balloon angioplasty, our L6 shockwave, and stenting of our bilateral iliac artery disease. And it started with the stick, which composed of 3 access sites, obviously bilateral common femoral artery, but we utilized the radial for the antegrade crossing with an R2P destination sheath. That allowed us to snare and externalize the antegrade wire through the left common femoral artery, to allow for the L6 shockwave through our larger common femoral artery sheets for our severely calcified iliac arteries, and then finally allowed us to optimize our balloon expanding stents and vinyl kissing balloon angioplasty. Thank you for your time and for our team.
Fantastic case. So I agree with you. Crossing these tough CTOs, especially in the iliac, it's important to have multiple areas of access so that you can really attack this come to battle. So just one minor comment about the initial kind of attack from the radial side. It is important, very important, to have the sheath essentially as close as you can, because it really offers you a lot of support. You may not really appreciate it when you're kind of attacking the CTO, but everything that you do gets transmitted exactly into the subclavian artery, and it curves right on the aorta. So that's why it's important to have a sheath, and sometimes even with a sheath hubbed against a really tough lesion, especially when you're further down in the SFA popliteal. You have to recognize that some of this gets translated up there. I've certainly dealt with issues where everything just pops back up from that.
Thuy, I know you guys transitioned to a radial approach. Was there another option from a retrograde approach that could have been attempted prior to doing a radial approach, maybe using a specialty device?
We could have maybe pioneered and try to come retrograde.
Yeah.
That was discussed, but very shortly and aborted and went more radial.
Perfect. Thank you.
Go ahead. You used Astato to cross eventually?
Yes, sir.
Is that your first line, wire for iliac CTOs, or do you try 035 system, with stiff glide or something?
Yeah,
first?
I'll be honest, in my early training in peripheral, I usually or have seen mostly starting with a command 018, and it's pretty much operator dependent as far as which guide they use. We did not try the glide wire in this particular case from the antegrade.
Thanks for presenting a great case. The other thing that Dr. Lee really resonated with me is just having that sheath ready to go when you're dealing with maybe a little less common iliac, but definitely external iliac, chronic total occlusions. You have to be really ready to go and prepared to treat rupture, which can be, pretty exciting when it happens. And if you don't have a radial sheath in, and you're trying to get a radial sheath in the midst of, trying to get a balloon tamponade and, prepare your Vibon, all of that stuff probably could have been simplified if you had just started with a radial sheath and had that proximal support to Dr. Lee's point. But I also think it's great to have that ready to go in case of emergency. So when you're crossing these CTOs, there are a number of ways to tackle it, but just always making sure you have your bailout options ready to go to save the patient.
So you're saying to go ahead and start with that R2P destination?
Yeah,
to
if
begin
you
with?
needed the
Yeah.
radial, nothing wrong with how you crossed it. I think it turned out great, but to Dr. Lee's point, probably would have made sure that I had that R2P sheath ready to go and had a good 8-French sheath from the groin ready to go and try to narrow my base of operations to
Absolutely.
just that 30 millimeters of CTO and to kind of ensure that if something did go horribly wrong, I was ready to treat it.
Yes, sir. Thank you.
Invite up Dr. Vijay Kandula to talk about endovascular treatment of erectile dysfunction secondary to tyrosine kinase inhibitor associated vasculopathy. Thank you.
Hello, everyone. Can everybody hear me in the back? Good? Okay. Thank you for giving me the opportunity to present today. I'm honored to present this case on behalf of my colleagues, Dr. Park, and my attending Dr. Rain, and my fellows here at UT Health, Dr. Bellera and Dr. Chauhan. Let me see. Okay. Okay. So I don't have any disclosures. So for us, the patient presented to Dr. Rain's clinic, which I work in. So a 29-year-old man coming with erectile dysfunction. Of course, it's alarming for the patient and for us as well. He has a little bit of complicated history. He has AML that was treated with chemotherapy, but then they had graft-versus-host disease after his stem cell transplant, and then he was treated with sorafenib, which is our VEGF TKI inhibitor, as salvage therapy, basically for this AML. And he's had cardiovascular history as well after the sorafenib treatment. He's had multiple stent space for a CAD. He had developed heart failure, and then he had peripheral vascular disease as well, requiring a couple of stents as well to his arteries. So when a patient comes in, of course, as an internal medicine resident, I'm going through all the different causes. So psychogenic causes, neurogenic causes, and then Dr. Rain comes into the clinic and is like, what about vasculogenic causes of ED? And of course, you have arterial ED with plaque buildup in arteries, and there's also venous, which is the venous leak syndrome. So the outgoing blood supply not draining as well can also cause these symptoms. Just quickly, the anatomy. So we were mostly concerned in this patient, the internal iliac, the anterior division portion of the artery, and then we were looking at the internal pudendal and the supply to the penis. So the initial angiogram, the left iliac, as you can see, there's a proximal obstruction, and then the right iliac. Oh, go back. All right. Let's see. Not sure why. Okay, so the right iliac was a proximal obstruction as well. So we ended up doing a 6 French catheter to engage the second anterior division and use a high torque pilot kind of to guide the occlusion, wired occlusion. And then we initially pre-dilated with balloon, treated with 3 different stents for the patient. As you can see, the last one was stent deployment. And that was the left internal iliac. And after the stents were put in, we got some good blood flow in there. And then the right internal iliac, similar. We use a high torque pilot to wire the occlusion, then we dilated and deployed stents as well. Okay, and then we ended up getting some good flow in internal iliac as well, right side. So post-procedure, patient did well. He was continued on DAPT and statins with complete resolution of symptoms. Even at 5-year follow-up, he had patent stents for him. So the clinical challenge for us was realizing the cardiovascular toxicity of these chemotherapy that patients might be on and associated CVD and risk factors. And then erectile dysfunction due to critical bilateral artery insufficiency, and then management of that. And then improving some of the monitoring parameters for these patients, especially sorafenib treated patients. And the resolution was we had to treat both the internal iliacs to restore blood supply to the pudendals. And understanding some of these VEGF inhibitors, there's more data now, so it's the monitoring and follow-up have to be more frequent. And just being cognizant that internal iliac disease is a cause for erectile dysfunction. Sorafenib can cause small vessel disease, and PTA plus or minus drug-eluting stents might be needed to treat this. And we might need close monitoring of some of these patients that are on sorafenib and other chemotherapeutic agents that are TKI inhibitors. Thank you for the pen.
Interesting case. Just out of curiosity, did it resolve his symptoms?
Yes, yes. So he's had multiple follow-ups for his cardiac disease, but for some reason he seems to be doing very well with the arterial insufficient treatment.
And I know these stents are open after 5 years, but are there other surgical options for particularly young patients that may have a longer patency than peripheral stenting?
So there are surgical options, but in this case, we ended up going with stents here. But yeah, there are surgical options. But he at the time, didn't necessarily want surgical options.
Understand?
This is really a little bit disturbing to see these things. I'll tell you why. It's a real serious thing. Not a cardiologist do not know about vasculogenic cause of erectile dysfunction. Not that I'm an expert. My mentor, John Ladd, was one of the part of the trial from Sacramento about 10 years ago called Zen trial. We were part of it. 50 patients, Medtronic paid $6 million for us to do the trial. We could not identify properly what are the causes. And we know patients with multiple coronary artery disease are the ones who get erectile dysfunction. And Leriche syndrome, everybody knows you treat aortoiliac segment, they get better. But when it comes to internal iliac arteries, I wouldn't be such cavalier just to cross a lesions and think I know what I'm doing and putting stents. The 50 patients, 10 sites, each 5 sites, including my side. When we did the review afterwards, 32% of the time we did wrong stenting of the where we thought was not the pudendal artery because we didn't know what we were doing. Radiologists know this stuff in and out. They are very good at it. We cardiologists are not good because these are small arteries, hard to identify the branches. I do uterine embolization, I do embolization to a prostate, but it's a very tough one. You got to have the radiology help. You got to know the anatomy in and out. And I wouldn't be cavalier about putting 2.5 pudendal stents. We did the Onyx stent in the Zen trial. I'm surprised at 5 years this is patent in a guy with so much vasculogenic, but I trust and I believe you. But our stents did not last. So there is a methodology to this madness. If for young people like you should read up from a guy called Sangiovini. You will call him Max. He's the master of this erectile dysfunction in Rome, Italy. He runs a conference along with the EuroCTO on September 7th and 8th. You can attend that. In January, he runs just ED. He's a physician trained at Mayo Clinic, then went back. He's written a book with David Holmes on erectile dysfunction, details. You first ask a questionnaire about International Erectile Dysfunction Questionnaire. It's a 38-page questionnaire. If the patient answers to fail 28 questions, then you know he has an arterial component to it. Then you do a special, you got to team up with your andrology center, and then you do an vasculogenic ultrasound. That means you give papaverine to the patient and you do ultrasound of the penis to see is there a problem with the filling of the cavernous system in the penis. If there is a problem, then you see if you can deflate it to get the blood flow out, then you rule out venous. So if there is an engorgement problem that fails to fill, you suspect there is internal iliac disease, then you put the patient on any of the PD-5 inhibitors, Cialis or Viagra. If they fail that, then you know there is an arterial blockage. Then you go and do both the internal iliac angiograms. In these cases, we just put the stents in the proximal internal iliac. The sizes are never 3-4 millimeters. It's usually 6, even up to 7 millimeters. So if you are doing a coil embolization of the internal iliac for a AAA, you don't put 2-3 millimeter coils. It's never going to occlude it. Or if you have a trauma from a pelvic embolization, you need huge coils. So you need to put 5 or 6 millimeters just in the ostium. And then the rest of it will start to pick up. Then you can come back and identify the pudendal artery. How you do it is on the table, you give some papaverine, the person will have erection, you do an angiogram. Then you know which is the artery going to the penis. And these crazy patients will tell you, let me go half an hour to my home and come back. You tell him, no, you can't, just stay back. Then you wire it while it's erect. Then you know where the wire is. Then you let it deflate. The andrology center will help. Then you know where the penile artery is. Then we even do an IVUS. Then we are using drug-eluting balloon now. It's part of the Magic Touch balloon company. We are using drug-eluting balloon because the artery is diffuse and long. And I'm not sure that putting the big stents help. So there's a lot of methodology to madness, and you have to be careful because we go like cavalier and you block off the posterior branches. And you take off the hemorrhoidal artery, you can get bad colonic infection in these patients. Internal iliac is a big collateral to the small intestine, and you can get into real trouble.
Okay. Thank you for that information.
Sorry for the long one, but some of it is really disturbing.
It's good to know.
We learned so much in 5 minutes with you, so I think we need to get you to give a talk next year on this topic.
We're going to be part of the trial, so we are hoping to get Dr. Junli and Mehdi to be part of this, but I'll get you guys involved. This drug-eluting balloon for erectile dysfunction is going to be a trial in the United States.
Okay.
Yeah, thank you for that. I appreciated that too. You know, we did a little bit of this in my fellowship training, and the thing that I remember is 85% of vasculogenic erectile dysfunction is actually venous leak. It's got nothing to do with the arteries. We see iliac artery occlusions all the time, and yeah, it certainly is tempting to do this. This poor young soul had bilateral iliac artery occlusions. That is a little unusual. I also wanted to just make the point that these tyrosine kinase inhibitors certainly cause arteriopathy, and it's very different than the atherosclerosis we treat from, vanilla cholesterol and plaque buildup in the arteries. It's very recalcitrant to conventional angioplasty and stenting. There's been some case series on TKIs that have looked at a number of different patients treated with these TKIs. They universally have really poor outcomes. They have very poor patency. It is not the typical pathogenesis of atherosclerosis that we treat. So I think just a word of caution that as TKIs become more important in the treatment of oncology, we are going to see this in our practice, and just to be aware that it is really a difficult condition to treat. And the few patients that I have treated, we've worked with the oncology team to switch them to a non-TKI-based regimen if it's possible to prevent the progression of this vasculopathy.
Thank you very much. That's Dr. Rain, by the way.
I don't know, you're absolutely right. So I think this gentleman, like I said, kind of rare because he does have a lot of small vessel disease. And he's had maybe 5 or 6 coronary angiograms since then because he's living off of an OM and an PDA. The other he's gone. And even for what's surprising about the internal iliacs is that, we rarely do this, as you pointed out. It's rarely done. And in this case, I think the idea of occluding side branches, there weren't any side branches to occlude necessarily. I think you're going through an occlusion. Surprisingly, I'm not the biggest fan of Resolute, especially kind of the ISR, but his Resolute stents have stayed open. So his coronaries within synergies and Orceros, and they've been recruiting. But these Resolutes have stayed open after 5 minutes, it's not 7 years. And he still goes to MD Anderson. I think they didn't change his regimen. But he's in a better place now than he was. And surprisingly, this didn't work for his ED. So.
The reason only I was commenting is, after all of this, we went to the FDA and said, listen, those stents were open. Despite the 50 patients, we might have put in wrong arteries. Why don't we work on getting an IDE, investigation device exemption? You know what the FDA said? Do a 1-to-1 placebo trial, just like our renal denervation. You prove the point because they think a lot of it is high up. Yes, there is vasculogenic component, but there's a lot of placebo effect, they think, which I saw because for screening angiograms when we did, they came back and said, oh, everything is working well. I'm like, this was screening angiogram, we never did any intervention. So there is a lot of placebo effect. So even though we're going to be part of the trial, the FDA is pushing and say, you do anything we want, regulating balloon, all of that, do a 1-to-1 placebo, put the sheath and don't do anything, then let us know, they're saying.
I think that's reasonable. And I don't know if you already mentioned this, but the Zen trial that happened, I think about like a decade ago.
Yeah.
And we were part of that also. And again, what we found out was exactly this, that most of these are not arterial insufficiencies. So even though you have the occluded sort of iliacs, their issue was more vasculogenic or sort of venous or psychological or neuropathic. Actually, they got him out. Well-made points.
Thank you. We were able to resolve the slide issue? Okay. Dr. Alom?
Hi guys, again, my name is Modar. I'm presenting about wiring dual layer stenting, instant restenosis using a Astato wire. So I have no disclosures. We have a 68-year-old male patient with non-healing ulcer in the medial dorsal aspect of the left metatarsal bone with recurrent event of critical limb ischemia, Rutherford classification in class 4. He had multiple intervention and was offered an amputation, and that's why he was referred to us for a second opinion to intervene on the anterior tibial artery and to hopefully avoid an amputation. His parental history, this guy has an extensive peripheral vascular disease. He has 6 interventions in the past, including left mid SFA, distal popliteal, he had dual layer of stent, anterior tibial, peroneal arteries. In the last intervention, they did the laser atherectomy of the occluded popliteal, peroneal, followed by DCP, and the fanial angiogram showed occluded peroneal distally, and the PTA and ATA are gone. So it's one distal, one vessel runoff, and he has some collateral going to the ATA. CABG, AVR, he's chronic kidney disease stage 3. We could not use the dye freely. because of that as well. So he continued to have the symptoms and came back for the second opinion. The challenge is he has so many interventions through the femoral axis and complications, obese patients. He has ostial ATA, CTO with 2 layers of stent, and you have no good flow distally as well. And the other challenge also, his creatinine is like 3.5. Axis, so we gained 2 axes, radial axis for imaging, and we got a left pedal axis using micropuncture kit. It was blocked, actually, we had to open it as well. So this is his peripheral angiogram. And I do apologize, I don't have the video, but it's occluded distally, the common peroneal. You can see the ATA is gone. You can see we're trying with the command wire, multiple attempts. It won't go through. And again, we're trying to go, because it's heavily, because it's severely, you can go there, you can see the wire goes between the stent and the wall. So finally, we used the Astato 30 guide wire, and it poked through the lesion. It was supported by Navicross, sorry. It was support, I don't call it. So then we ballooned left popliteal into anterior tibial. Then we did the DK crush using a Corsella balloon coming from the radial into the peroneal. The mid ETA was 90% as well. We placed a self-expanding Innova stent. Despite what we did, we still did not have a good flow. As you can see, it's only threaded. We used the DCP afterward. Then we use Shockwave. I don't think the video is working, but oh, it's working now. And then we still did not have a good result, so we placed an proximal ATA stent, and that's our end result. The patient followed up 2 months afterward, and he said he can do 1,000 steps a day. He doesn't have claudication anymore, and that's all. My key learning are widening through peripheral CTOs could be challenging, especially if you have multiple layers of stents, complex lesions. Astato wire has sharp tip and designed for complex, heavy CTO peripheral cases. Knowing your wires and knowing your lesion preparation before the intervention is key here. And the other learning is you could use radial artery R2P is also helpful in those cases. Thank you, guys.
Thanks, Modar. Would you actually classify this as 2-vessel runoff at the completion?
Technically, we can't, because the distally the common peroneal is occluded, but I can't say if it's one or two. It's
a bit of a misnomer.
1.5.
Yes. And the other question I have is, was the anterior tibial patent all the way to the lower extremity distally?
Yes. Yeah.
Yeah. I questioned that as well. It looked a little bit occluded.
It's we can go back to that.
Yeah.
But we did not feel it was it was not occluded because we thought it was open all the way. The PT is gone, yeah, from before.
So just some tips for you. If you're going to show these cases, always show the full runoff to the foot to begin with, because we don't really know what's going on below. I think you said Rutherford 4, but this patient had a non-healing ulcer, is that correct?
Yes.
Okay. Did the ulcer heal after all of this?
That I did not follow up on.
Okay, I mean, the whole point of doing this is for ulcer healing, right? Treating below the knee for claudication is questionable at best, right? So yeah, anyway, those are my comments. And then this just tells you why we should really avoid stenting as much as possible at the tibial plateau, below the knee, popliteal. I'm happy with what you did there, but I guarantee you it's going to occlude pretty soon.
A couple of points. This case was actually presented yesterday, I believe. So I think one of the things from prior interventions that were not performed by you guys was the ostium of the AT was completely missed on the prior intervention. So I think that's probably what had led to recurrent occlusions. And we discussed this ad nauseum yesterday. Ensure your inflow and ensure your outflow. So that's the first comment. Secondly, because there's a sheath now in the anterior tibial artery, which is the runoff to the foot, it may be difficult to visualize the foot afterwards. But it is important to understand what the outflow looks like into the end organ, which is the foot, before you perform the intervention.
Thank you. Thank you.
Yeah, I was just going to make the same comment, make sure that you're accurate in your classification. So this would have been either a Rutherford 5 or 6 patient, not a 4 patient. Because when you communicate this to your colleagues, you're going to need to be accurate, and I think that's important. And then, we can certainly see shortcomings in some of the recently published data from BEST CLI and Basel II. There's certainly a lot of challenges with those studies in a very difficult population, but not to forget that bypass surgery, if somebody has a saphenous vein graft, after all of this stuff was done before, is still something to keep in mind. So just to be thoughtful as you're looking at these patients, and you've done due diligence before you have to go in, not saying that this wasn't the right thing to do for this patient, but just not to forget about all that distal saphenous vein bypass, if it's feasible, the patient's cardiovascular risk is acceptable, and they have a good conduit, is still a very reasonable approach too, particularly for healing lower extremity wounds.
Thank you. That's a good point. Thanks. Any questions?
Thank you so much.
Thank you.
Let's go back to Dr. Edeboyol. Bolu, sorry.
Good morning. I'm Olayinka Adebolu. I just graduated residency, and I will be presenting an unusual case of chest pain. The authors have no disclosures. Something obstructing me. So I'll present a 68-year-old male who came in with acute urinary retention, and he developed sudden onset typical chest pain while a Foley was being inserted. Physical exam was remarkable for only reduced left radial pulse amplitude and volume. He was also in painful distress. Past medical history was a history of CABG, limited LAD, and the rest stated above. He had paroxysmal AFib, CVA, prior aortic repair, tobacco dependence, and vertigo. His troponin trends were not completely significant. The peak was 0.11, and his EKG showed T-wave inversions in the anterolateral leads. That's the EKG a year prior. Echo showed hypokinesis of the anterolateral, anteroseptal, and the apical regions. So we proceeded to a left heart cath. I'll just breeze through them because of time, but the things that we majorly noted were he had RCA stenosis, and he also had some vein graft stenosis. Some were old, the SVG to OM, and the SVG to RPDA was new. At this point, we went to the aortic angiography, and it was pretty difficult to navigate through the aortic arc, and we began to suspect that he probably had another type of anatomical variant of his aortic arch, or there was possible subclavian artery stenosis of the left. So we stopped the procedure, we had to take consent from the patient, and we did a CTA showing calcification around the arc of aorta and almost subtotal occlusion of the left subclavian artery. So we proceeded to do a subclavian artery intervention. We went through the right common femoral artery. We used the 7 French, and then I'll just show videos so I don't run out of time. This is the angiography of the aortic arch, and this is the DSA. This is before pre-angioplasty, and that's the picture showing the stenosis. And this is where we did the intervention. So the intervention was pretty complex. Initially, we used a VTK wire, VTK catheter, but then it wasn't successful. Then we changed to a JR catheter, and we used the body wire technique using the 014, 2 014s, before we changed to an 035. So I'll just proceed to show our procedure as we went through it. So that's us using the body wire technique. And this is us with the balloon angioplasty. And this is after the balloon angioplasty. And then we put the VBX stent. It was balloon expendable, covered stent. And after that, there was good flow. This is post-stenting. And the next one was when we checked the Lima runoffs, it had good flow. So follow-up, patient continued to do well after the subclavian artery stent placement. He was sent home on DAPT and statin. And it's just important for us to know, like the previous speaker spoke about, that coronary subclavian steal syndrome is a complication of people with subclavian artery stenosis that have had Lima from CABG. Challenges that we faced here was that it was difficult to tell the anatomy of his aortic arch. We thought it might be type 2 or type 3 because of the tortuosity. And we also thought that there might be a possibility of having a bovine arch as well. It was also pretty difficult to locate the ostium of the left subclavian artery. That's why we didn't bother to use the radial axis. And on top of that, he had heavy calcification and almost subtotal occlusion of his subclavian artery. So we had to go back, re-strategize, and plan to stent this challenging stenotic subclavian artery. And the learning point is that we should have a high index of suspicion for coronary subclavian steal syndrome in a patient that develops chest pain who had a history of CABG that involves the internal mammary artery. And the importance of CTA cannot be overemphasized. Thank you.
I think one also important step to acknowledge while you're performing these subclavian stenoses is obviously a challenging lesion and very calcified. I oftentimes obtain a carotid ultrasound as well because I can tell whether or not the vertebral artery has antegrade filling versus not. Certainly the risk of vertebral artery stroke is there, especially in a heavily calcified or thrombotic subclavian lesion. I've personally done vertebral artery protection in patients that have needed a subclavian stent still with antegrade flow through their vertebral arteries.
You mentioned at one point in time there was some consideration for retrograde recanalization. Why was that not selected?
I'm not actually sure why we didn't select it, but I think there was a discussion with it, but I'm not sure why it wasn't selected.
Yeah. Sometimes for very tough subclavians, that can be a very, very easy way to cross tough lesions. You're much more closer to your vessel. Being more accurate with stent deployment also is a possibility. The downside being it's a large sheath if you're going to use a VBX. So in that situation, you could cross from a retrograde approach, get your femoral access, buddy your wire, and deploy the stent from below. But if you run into trouble, that's one good way to overcome it.
Thank you.
Just from the beginning, if you watch it, I'm not sure the subclavian was causing all the problem. If you look at your first echo, everything, after Foley, how many people get MI? It looked like Takotsubo, but I'm not a big expert. I may be wrong because if you look at that LV, you showed its base is contracting and the apex was dilated and the T waves were flipped. I don't know if this was like.
Yeah, we had that discussion as well because he had like LAD territory pathophysiology or Takotsubo with the global. But then by the time we saw that stenosis, we also thought coronary subclavian steal syndrome could be a possibility as well.
Remember before Takotsubo was named, we didn't know what it was. And my mentor, without naming him in Georgetown, used to IV us all of them, and we found something in the proximal. He would say, see, this is the problem, not this stupid Takotsubo. We would stent all the LAD for not knowing, but Yeah, yeah. We do it all the time, and if you IBUS them, you'll find something, the mind plays games, but Mahmood works with me, he's a smarter guy, but that was just something to think about.
Okay, thank you.
Do you know if the EF got better?
I'm not sure about his EF, but I think it was stable.
One point to Dr. Lee's statement, why don't we see more strokes from subclavian artery interventions? And one of the reasons is, even though we fix the antegrade flow, the component of retrograde flow down the vertebral doesn't normalize right away. It takes some time. So you get sort of built-in neuroprotection. And, a lot of times when you have this chronic underfilling of your left vertebrals, people's right vertebral does a lot of work, particularly, if you have an intact circle of Willis. So you sort of have the pseudo flow reversal protection after stenting for some time.
Yeah, I think Bill Gray published that data set, and I don't know about you, June, but usually I don't fix subclavians if the retrograde flow, if I don't see retrograde flow in the vertebral artery. If it's antegrade, there's probably enough flow through that subclavian. I don't know how you feel about that, but that's why I've never had to use any embolic protection in the vertebral artery.
Yeah, I think that specific case was actually a thrombotic lesion. So yeah.
Thank you.
Any other comments? Okay. Last but not least, we'll invite back Dr. Thuy, Pham, to discuss endovascular intervention of femoropopliteal bypass graft, distal in-stent restenosis via the transfer.
Good morning again. I will spare you guys the reintroduction, but I will preface saying this case was accepted only after another case withdrew. So if this case doesn't win, I think it was destined not to. So, but I will share, thank you for letting me share an endovascular intervention of a fem-pop vein graft distal anastomosis disease via a transradial approach. Surprise, surprise, I still have no disclosures. Our patient is a 75-year-old male referred for right lower extremity Rutherford class 3 claudication. His PAD, his history is quite significant. He had a recent left common femoral endarterectomy, and that was after a left fem-pop bypass a year before with left iliac artery stenting. He had multiple right lower extremity angioplasties, followed by a right lower extremity fem-pop vein bypass graft as well, with subsequent distal anastomosis TPT trunk stenting. His most recent bilateral arterial duplex was significant for severe right perineal artery disease and more than 70% stenosis at the distal anastomosis of the right fem-pop bypass. His ABI on the right was 0.84, and he had velocities in the perineal in the 200s. He rounded that out with hypertension, hyperlipidemia, diabetes, non-obstructive CAD, and mild coronary artery stenosis. So we started with a 6-French sheath and a 125 JR4 diagnostic catheter for transradial selective right lower extremity angiogram. You see here 70 to 80% right external iliac disease, instant restenosis, and occluded right SFA, a patent right fem-pop bypass, but distal disease on that last picture of the distal anastomosis into the TPT trunk. Mostly a 2-vessel runoff to the mid-lower leg via perineal and PTA, but severe disease proximally of both of those arteries as well. So our clinical challenge is this. He has multi-level right lower extremity PAD of the external iliac artery, the distal fem-pop vein graft bypass anastomosis, and infrapopliteal disease as well. So our plan was to come from the transradial approach, which we already had, and to tackle the distal fem-pop vein graft bypass anastomosis disease, and then pull back proximally to address the external iliac artery disease. So we switched out here for a 119 centimeter radial to peripheral destination sheath, and with a Navicross and Command 018, we performed serial balloon angioplasty with a Crostella 235 by 40 balloons. And then we did a drug-coated balloon angioplasty with a 5 by 80 impact balloon in this area as well. This is our pre and post imaging. We do see improved flow through that distal anastomosis into the TPT trunk and perineal arteries, but we weren't happy with the proximal PTA. We did attempt to cross this with our Command 018, and we were worried about further propagating the dissection. So we called an audible and obtained right distal pedal PTA access. With a with a 018 wire, we performed balloon angioplasty with a 3 by 40 nanocross and a 3 by 150 coyote with our final results here. We then moved proximally back to our transradial approach to address the right external iliac artery, performing balloon angioplasty with a 5x40 cross stella and a 7x100 Ranger drug-coated balloon. And this is our final pictures of the right external iliac artery. So the resolution of our challenge of having multi-level PAD, our left common femoral axis and pedal axis were not ideal, so we decided to use a transradial approach. The right lower extremity FemPop vein bypass graft was addressed with serial PTA and DCB from the right radial approach, and then we were able to do the same with the right external iliac artery as well. And our key learning points for here is this wasn't a difficulty crossing case at all, but it was more just kind of novel uses of access and devices. A transradial approach is emerging and as a reasonable option, even for more distal femoral popliteal areas, especially with the longer 200 centimeter shafts of their drug-coated balloons. And we can use the transradial approach even in conjunction with pedal access because it allows for sort of better imaging in an antegrade fashion. And lastly, we know the utility of drug-coated balloon angioplasty in our native lower extremity disease, but in this case, we demonstrated that it could also be used for bypass vein graft disease as well. Again, thank you guys for your time and our team on this case.
Thuy, nice salvage case for a potential bypass that was going to fail. Two questions for you. One, it appeared that the right common femoral just below the level of that stent had a moderate grade stenosis there. Was that viewed with any other imaging technologies such as IVUS to assess?
Not in this particular case, sir.
Do you worry about that lesion, being a potential source for ultimate failure for the bypass graft?
I think so. Anytime we're looking at lower extremity PAD, which you guys have mentioned, inflow and outflow is so important. So if we fix the inflow, but yet our outflow to our external iliac is not good. I think angiographically we felt it was okay and left it alone, but we did not further evaluate that lesion.
And then secondly, when you did the distal balloon angioplasty of the posterior tibial, did you consider doing kissing balloon angioplasty to ensure that the perineal, was that perineal?
It was perineal,
yeah,
yes, sir.
because it looked a little bit stagnant on your final angio.
I understand, yep. So that was discussed as well, and that was one of sort of, again, the benefits of having both the radial and the pedal. But again, angiographically, we felt it was okay and did not further intervene at that point.
The drug-eluting balloon in the external, was it a 100 millimeter balloon?
Yes, sir, 7x100 Ranger.
So I know there was a stent and it's protected, but just be careful using long balloons in the external. If you look at the anatomy, especially when you're doing TAVR CTAs, you can see the external dives inside and goes up, and then in the external, there's nothing to protect. It's all mushy, small intestine. So if you use a long balloon, it'll ring the artery and it can rupture it. And coming from the radial to pedal, especially like Dr. Bunty was saying, you won't have enough time to salvage it putting a long covered stent. You can get away with even a balloon expandable, but putting such long balloon expander is hard. With the stent, it's harder to rupture it, but it can happen.
Yes.
So usually what we teach the fellows is just take a short balloons, 40, and then keep dilating. That's more safer.
Yep. Thank you, guys.
Thank you.
Thank you, everyone. We'll take a short break, and I think the next peripheral session starts